Out of that, now what we will do is that we'll touch upon adenomyosis. We have a separate talk on fibroids next time. We also will discuss something about ACM and some of the special cases. We'll see some of the sample reporting of adenomyosis. Fibroid we'll see next time. The consensus on revised definitions of morphological uterus sonographic assessment. This was the article in 2022, where this Delphi procedure modified some of the terminologies, out of which direct signs and indirect signs of adenomyosis is one of the key features. They stated that direct signs are cyst, presence of hyperechogenic islands, echogenic striations or subendometrial lines or buds. These are absolutely direct signs of adenomyosis, where your level of confidence and specificity in stating it to be adenomyosis is very high. There are indirect signs of adenomyosis like asymmetrical anterior or posterior wall thickening, fan-shaped shadowing, globular enlargement of the uterus, translesional vascularity when it's a focal lesion involving one or the other wall, endomyometrial junction zone, which is thickened, irregular, or interrupted one. So these are indirect signs and these are the direct signs. This is one of the hallmark feature of a modified consensus statement. Last many years, we have been reporting bulky uterus query cause, enlargement of the uterus with tenderness, what is the etiology, diffuse heterogeneous thickening of the uterine wall with motile ecotexture, what is the etiology, tiny cystic spaces mixed with the coarse ecotexture of the uterus and hypoechoic infiltrates in one or the other wall, what is the etiology. So all, in fact, we were describing were only findings, but no one of us was saying that it is a adenomyosis. And usually clinician used to ask, why, what is your opinion? What exactly you want to see? Now, looking at these two senior lobes, here you can see there is a globular enlargement of the body of the uterus. The cervix appears to be very short and thin as compared to the globular enlargement. If you look at the same senior lobe on transvaginal ultrasound, you can see that there is an involvement of anterior and posterior wall of the uterus. Endomyometrial junction zone is indistinct. Both the walls, they have Venetian blend sign. At the same time, there are mottled ecotexture of the anterior and posterior myometrium, in which there are multiple tiny cystic spaces involved. This is a classical description of adenomyosis. Now, looking at one more case. Now, what do you find here? You find that the endometrial ecocomplex is well appreciated, but I can see there is a tiny cystic space which is just adjoining endomyometrial junction. The endomyometrial junction in some part is thickened, some part is interrupted, and I can see that there is some interrupting kind of a feature within the endometrial cavity. Probably we are looking at some of the uterine cavity lesions. Now, if you look at the color Doppler feature, where you can take UMA, that is ultra microangiogram kind of a flow on in the uterus, you can see that it is taking the translesion kind, lesional kind of a flow features in case of the adenomyotic lesion adjoining to that. Now, if you reconstruct the endometrial cavity, here you can see the impression of uterine adhesions, which was nicely denoted on 2D senior loop. Also can be seen on 3D acquisition of the data on very nicely endometrial cavity assignment. So this is how you can see that this is a endometrial adhesions apart from asymmetrical thickening of endomyometrial junction. The delay in diagnosis of adenomyosis and endometriosis is because of overlapping symptomatology. Lack of voluntary effect on the part of imaging team could be one of the another reason. It takes almost 8 years to diagnose endometriosis or adenomyosis. Most of the people say that the ultrasound report can be normal. It can show a unequivocal finding like bulky uterus, tenderness, kindly correlate clinically. And all those individuals were subjected for either MRI or laparoscopy. But if you have a vigilant outlook towards identifying adenomyosis, you can find it out on good ultrasound equipment as well as color Doppler features. The imaging objective in cases of adenomyosis is a diagnosis, extent of the disease, and if along with adenomyosis, any additional features of deep infiltrating endometriosis present or not. Now, let us break down this term adeno and meiosis. Adeno means ectopic endometrial glands and stroma. Meiosis means muscular hypertrophy or muscular hyperplasia. So radiographics coined the term what is called the myometrial heterogeneity, which is characterized and equivocal to cirrhosis of the uterus, and that is because of adenomyosis and muscular myometrial vascularity. So adeno means ectopic endometrial glands, and stroma, ultrasound characterizations are echogenic striations and nodule, myometrial tiny cyst, cystic striations within the endomyometrial junctional zone, and myometrium. Meiosis, which is denoted by muscular hyperplasia or hypertrophy. Ultrasound characterizations are thickened inner myometrium, which is nothing but endomyometric junctional zone, myometrial asymmetrical thickening, focal or diffuse, enlarged globular form of the uterus, or different kind of a Venetian blind kind of a shadowing in one or the other walls. Myometrial vascularity could be increased, and those are showing penetrating vessels traversing the lesion seen in one or the other wall. The pathogenesis of adenomyosis is said to be tire theory, that is, tissue injury and repair theory, where the bacillus endometrium infiltrates into the myometrium through abnormal junctional zone. So most of the people, they say it's abnormality of the junctional zone. Few people, they say it's a metaplasia of ectopic intramyometrial Mullerian rest. So there can be a retrograde menstruation into the myometrial substance. Few people say that the menstrual content may escape from the fallopian tube and through the femoral end, and then the endometriotic deposits occur over the ovary or the superficial form of endometriosis. At the same time, some of the endometrium may get ectopically deposited within the myometrial substance. Now, adenomyosis, the role of imaging is for correct diagnosis and treatment planning, out of which hysterectomy is mainstay, but certain other conjoint newer therapies are also available. Now, our intent has to define what is extent and depth of myometrial penetration of adenomyosis, and also look for presence or absence of ovarian endometrioma or deep infiltrating endometriosis. Whenever the patient is under clinical trial, we need to monitor the evolution of the disease with conservative treatment. So the adenomyosis can be a focal adenomyosis, it can be focal adenomyoma, it can be a diffuse adenomyosis, and it can be a adenomyoma which is in one or the other wall of the endometrium. What are the various ultrasound features of adenomyosis? We will see in next few slides. The treatment options, particularly for severe dysmenorrhea, pelvic plane, or severe bleeding and infertility, could be medical treatment, high intensity focus ultrasound, or uterine sparing surgeries, and few of the debilitating hysterectomy surgeries, out of which the danazol and gonadotropin releasing hormones, GnRH analog, are the mainstay of medical management. So we have to decide depending upon stage and penetration of adenomyosis, which is the appropriate treatment protocol for the individual under trial. Now, one of the foremost thing most of us wants to know is whether the focal adenomyosis is distinct or is it a leiomyoma. The borders of adenomyosis are indistinct. In case of fibroid, it is distinct and round. The shadowing is thin, parallel, and vertical, called the Venetian blind kind of a shadowing, where it's the age shadowing, kind of a shadowing. We'll discuss all the features of fibroid and its characterization in next series. We must remember that the echogenicity can be mildly increased in case of adenomyosis. Calcifications are usually not a feature of adenomyosis, can be a feature of leiomyoma. The tiny cyst and cystic striations is a feature of adenomyosis. The increased vascularity and penetrating vessel is a hallmark feature of adenomyosis. But in cases of long-standing leiomyoma with degenerative features or fibroid with pregnancy, on many instances can show penetrating vessels. The endometrium can be normal, but the endomyometrial junction zone is thickened and it may be irregularly interrupted, or indistinct in outline. So we need to identify the fibroids and adenomyosis. At the same time, we also should consider that on many instances, fibroid and features of focal or diffuse adenomyosis can coexist in one patient. The IDEA group has defined a protocol to identify deep infiltrating endometriosis in four-step fashion, out of which the first and foremost step is sonographic signs of adenomyosis and looking for presence or absence of endometrioma, followed by soft markers on transvaginal for site-specific tenderness, assessing status of POD for sliding sign, and assessing deep infiltrating endometriosis nodule in anterior and posterior compartment with the view of transvaginal ultrasound. Now, the first feature in case of adenomyosis can be uterine enlargement. There is a globular enlargement of uterus, which may be increased up to the 12 centimeter in size, which is typically not explained in cases of leiomyoma. Uterine wall can be asymmetrically thickened and associated Venetian blind kind of a shadowing may be seen. This uterine wall thickening, anterior-posterior asymmetry is typical feature of a disease and it can be focal on many instances. Obscure endometrial and endomyometrial border or endomyometrial junction is one of the hallmark feature. Now, in all these three static image, you can see that I can make out the endometrial outline as a midline structure, but the triple line configuration is missing in all three. It can be seen in lower part of the cavity in image 3. At the same time, the endomyometrial junction zone is quite indistinct and it is occupied by multiple hypoechoic and hyperechoic infiltrate in adjoining anterior and posterior wall. Heterogeneous overall ecotexture of the myometrium giving mottled appearance in anterior and posterior wall could be a feature of adenomyosis. This lack of homogeneity within the myometrium is evidence of architectural distortion, and this alone can be considered as one of the most predictive value of adenomyosis. Thickening of this transition zone and this transition zone of hypoechoic halo surrounding endomyometrial layer is one of the hallmark feature which we call it as an endomyometrial junction zone or a busy zone. On MRI, typically we say that a thickness of more than 12 millimeter is associated with adenomyosis. So we need to look for thickening of transitional zone. Now, what is this thickening of endomyometrial junction zone? In fact, it is a zone of inner myometrium which is just adjoining to the basal endometrium and the functional endometrium, which is characterized by an hypoechoic halo adjoining to that. Now, in these two static images, you can appreciate that it is thickened. At the same time, some kind of a nodularity is extending from endometrium into the endomyometrial junction zone. So this is a nice article which explains that on 3D acquisition of the data, you can measure the endomyometrial junction zone thickness. At the same time, whenever you are attributing a focal adenomyoma or a fibroid, this is a classical focal adenomyosis zone, and you can appreciate on 3D that there is a thickening of endomyometrial junctional zone over there. We can measure the same, but by ultrasound characterization, mere thickening, abnormality of contour, interruption, and irregularity should be taken as a feature of adenomyosis rather than attributing any quantitative value of endomyometrial junction zone. The next one can be a subendometrial echogenic linear striations. Now, in this scene loop, you can appreciate that the endometrial triple line configuration is indistinct. At the same time, I can make out that there are fine hyperechoic nodules which are arising from endometrium and extending into the endomyometrial junction zone, which is indistinct as well as not appreciated in some part that is irregular. So this is the invasion of endometrial gland into subendometrial tissue as a hyperplastic reaction, and we need to always look for such kind of a striations or nodularity. It is said to be one of the most specific sign of adenomyosis. Cystic anechoic spaces or lakes within the space of myometrium could be one of the features. Now, in initial MUSA, there was a specific characterization as to in terms of size was given, but in 2022, it was decided that any size, shape, morphology can be considered as an adenomyotic cyst rather than measuring specific size for the same. The cystic changes in the outer myometrium may on occasion represent a small arcuate artery vein rather than adenomyosis, which can be easily picked up on just putting a color Doppler or a power Doppler. Now, this kind of enhancement seen posteriorly is called as the edge enhancement, and this is not a shadowing. So the next characterization is the cystic anechoic spaces adjoining endomyometrial junction zone. Presence of a hyperechoic strands or lines or islands is said to be the most specific sign which is disrupting the junctional zone. Usually they are perpendicular and in continuum with the endometrium. Coronal 3D acquisition can depict those linear striations entering from endometrium into endomyometrial junction zone very well. And you can appreciate in this serial loop, I can appreciate these echogenic striations as well as small islands which are situated adjoining endometrium in an interrupted irregular endomyometrial junction zone, which is thickened one. So the next one was hyperechoic strands or lines. Now, on many instances, you will find that there is a inhomogeneous endomyometrial junction zone, which could be interrupted, as in this case, because of uterine adhesions. One more sign which was described in literature is called the peg down sign or a question mark sign, which is typically seen in case of a anteverted uterus, which is retroflexed one. So here you can see there is a question mark because of cervix and lower part of uterine cavity, whereas the fundus is dipping down posteriorly because of adenomyosis and superficial form of endometriosis involving the serosa, or there could be features of deep infiltrating endometriosis involving the bowel, which is just behind the body of the uterus or behind the retrocervical component. This is called the question mark sign or peg down feature. Now, this Musa characterization by this article by Van de Bosch was meant for uniform terminologies which are reproducible, internationally acceptable, classification becomes easy and grading becomes easy. So reporting of adenomyosis depending upon this Musa consisting of 7 points, that is presence or absence of adenomyosis, location of adenomyosis, differentiation of adenomyosis as a focal or diffuse or adenomyoma. It could be cystic variant or non-cystic variant depending upon dominant nature of the disease process, uterine layer involvement, 1, 2, 3, or combination of this, extent of the disease as mild, moderate, or severe, and if there is a focal adenomyoma lesion or a focal adenomyosis lesion in one or the other asymmetrical thickened wall, we need to measure the size of the lesion. So let us see one by one. So whenever we have seen that there are direct and indirect signs, and these indirect signs could be asymmetrical wall thickening, it could be globular thickening, but the specific sign should be cyst, hyperechoic island, fan-shaped shading is the indirect sign, interrupted zone of endomyometrial junction zone or the irregular junctional zone could be an indirect sign. Translesional vascularity could be indirect sign. Echogenic endometrial lines and bursts could be a direct sign. So this can be the features of direct and indirect, which was modified in 2022 article. Let us take one by one 7 points. In contrast to this senior loop, which obviously shows a normal homogeneous myometrium equally placed adjoining to endomyometrial ecotexture, which is triple line feature. What about this now? I can say that it's a retroverted uterus. It's an asymmetrical thickening of the posterior wall, which is occupied by area of adenomyosis, characterized by a mottled appearance of inhomogeneous hypoechoic infiltrates, intermittently seen with a tiny hyperechoic cystic spaces within the same. So presence of adenomyosis is number one. The next one is the presence or absence of 3 features, that is subendometrial lines, subendometrial buds, or hyperechoic islands. Now, in this senior loop, you can appreciate that there is indistinct, irregular, thickened endomyometrial junction zone, as well as you can see all the signs. What are the signs? They are hyperechoic echogenic strands, presence of an island, as well as strands which are arising from endometrial junction. And I can also demonstrate tiny cystic spaces adjoining to thickened area of endomyometrial junction zone over there. So I have to be always vigilant in looking at endomyometrial junction zone adjoining to endometrial triple line configuration if may be thickened, irregular, interrupted, along with presence of a hyperechoic strands, buds, or linear echogenic striations, which could be one of the common hallmark feature. Location can be in the anterior wall, posterior wall, fundal. It can be even lateral wall, and it can be demonstrated on sagittal and transverse plane, but localization becomes more easy on 3D and 4D acquisition of the data. Now here you can appreciate that this is a retroverted uterus, and within the fundus I can demonstrate an adenomyotic zone which is characterized by intralesional branching kind of a vascularity rather than a circumferential vascularity. I can also demonstrate a small variant of a typical hematosalpinx in the right adnexa. So this is a feature of adenomyosis. In terms of differentiation as a focal diffuse or mixed, we need to look for what is whether the lesion is less than 25% surrounded by a normal myometrial tissue, which means that it's a diffuse lesion. If the lesion within one or the other wall is more than 25% circumferentially surrounded by a normal myometrial tissue, then we are dealing with what is called the focal disease pattern. So that's a differentiation between focal and diffuse one. There can be a mixed variant where both the variant can be a dominant feature. Now, we have seen the earlier feature was demonstrated on the sagittal, axial, coronal, and 3D data, but here differentiation in terms of focal or diffuse need to be done only on sagittal scan. If we are unable to differentiate and state between focal and diffuse, it is better to treat it as a diffuse disease. If both focal and diffuse changes are seen in different locations like anterior wall, frontal wall, posterior wall, it is defined as a mixed variant. Now, in this patient, you can see that there is intralesional branching kind of a vascularity, and you can see that indistinct endomyometrial junction zone and a thinned out endometrial ecocomplex within the same, mottled appearance and heterogeneity in terms of wall ecotexture. The next one is the cystic or non-cystic variant. So measurable fluid more than 2 millimeter is need to be said. Somebody is putting some scratches on the images. I would request that because that will hamper the quality of presentation. So it's a sincere request whoever has done to undo the same, because it is not possible for me to do it again. So it's sincere request if somebody has done this architecture on the slide to remove the same. So measurable fluid can be more than 2 millimeter in size, but this characterization of more than 2 millimeter was removed in 2022 article. There may be echogenic rim, which should be reported, and cystic variant itself is enough to the same, and we need not measure the size of the cystic lesion for that matter. Now here you can appreciate that it's a intrauterine pregnancy along with a small cystic area adjoining endomyometrial junction zone along with a punctate area of what we call it as a comet tail artifact. So in the next, we are looking at what is called the focal adenomyosis, diffuse adenomyosis, or adenomyoma, depending upon what kind of lesion it is. And we need to look for this variant only in cases of sagittal scan and not in cases of a transverse scan or axial scan or coronal scan on 3D acquisition of data. Here you can see that this focal zone of adenomyosis is encompassed by normal myometrium to the tune of 100% almost. Here it is 25% or less than even that. And whenever we think of adenomyoma, the new terminology says that it should not be in conjunction or continuity with endomyometrial junctional zone. Now, whenever it's a uterine layer involvement, it can be a junctional zone, which is type 1, middle layer, which is type 2. It can be type 3, which can be defined on color Doppler very, very easily. In those patients where multiple layers are involved, sliding signs should be seen for deep infiltrating endometriosis. And whenever more than one layer is involved, we can label it as a layer 1 and 2 is involved, 2 and 3 is involved, or 1-3 means 1, 2, 3 all are involved. So uterine layer involvement is very, very important characterization. And see, this is the endometrial cavity. This is endometrium per se. And the adjoining territory is the inner myometrium. This is middle myometrium. And this is subserosal surface, or this is layer 3. So we are dealing with a junctional zone, which is type 1. Middle endometrium, it's a type 2. And the outer myometrium is type 3. On many instances, you can find that there is a tiny cystic spaces which shows cometal artifact. In this individual, you can see that there is a marina within the cavity and there is asymmetrical thickening of the posterior wall. Not only that, the endomyometrial junction zone is indistinct and features of adenomyosis in terms of a mottled appearance in the posterior wall. Adjoining to that, we can see cystic spaces, which also has a small hyperechoic area within the same, which could be a feature of a clot within the adenomyotic cyst. Now, in terms of extent, it is more or less a subjective criteria. The estimation is basically involves looking at the pores proportion of the uterine corpus. Mild is said to be when it is less than 25%, moderate when it is 25 to 50%, severe when it is more than 50%. We can sum the volume of different lesion whenever they are considered. The last one is the size of the lesion. So largest diameter of a largest lesion should be considered. Each lesion largest diameter can be taken, but did not be mentioned in our final report. In case of a diffuse myometrial asymmetrical enlarged wall is only measured, we can take a ratio of this along with the normal one. So orthogonal plane measurement is upcoming and still we need to look for. Viraj, can you listen?
Yes, sir. But I'm not able to figure it out who is doing this.
What? Just let me know what we can do further.
Mira, just make me a host. Now I'll remove all this.
Okay.
Sir, 1 minute, sir.
I'm really sorry for rest of the audience because this really prevents the flow of the entire session. And I don't have any idea whatsoever what is the intent behind this. I mean,
I think somebody's kid might be doing something inadvertently. Somebody has logged in and the kid is playing with the pen. Something is going on like that.
but the issue is that, I mean, the precious time of most of the people, in spite of their own priorities, have given and devoted time
Right.
for academic session. This kind of, I mean, it's completely unwarranted. I mean,
Yeah, absolutely. I don't know what to do now. Yeah, next time we will disable this from
can,
everyone.
can I do a small trick? Let me stop sharing and
Yeah,
redo
yes,
that.
you can do
Yeah,
that, sir. Maybe
yeah,
that will work.
yeah.
I
Doctor,
do that.
stop sharing.
Sir, he's doing it, sir. Just a minute, please.
What, the complete thing is gone?
Is it okay?
Yeah, yes, sir.
Look decent now, no?
Yes.
So once again, apology on the part of me, I think. But anyway, let us proceed. Size of the lesion. So that's the last point to consider. Largest diameter of largest lesion we will take into account. Each lesion largest diameter can be considered. In diffuse myometrial asymmetrical enlarged wall is measured, and orthogonal plane measurement is upcoming. And I think as we have started doing the 3D mapping of fibroid, eventually we will end up doing the same thing. So it's as simple as that. Just to sum up, as far as the Musa criteria is concerned, we started with adenomyosis, location, differentiation, cystic, non-cystic variant, uterine layer involvement, extent of the disease, and size of the lesion. Now, presence or absence, location, anterior wall, posterior wall, left lateral, right lateral. But in terms of location, we have to consider axial and sagittal. In terms of differentiation, we have decided that we will be looking at only sagittal scans. Cystic, non-cystic variant, uterine layer involvement, layer 1, layer 2, layer 3, subjective assessment of an extent of the disease for that matter. Important criteria of adenomyoma, And adenomyoma is a focal region of adenomyosis, need to be differentiated from uterine fibroid. In case of a uterine fibroid, the contour of the uterus is typically distorted, taking into consideration the myometrial or serosal outline or the type 4, 5, 6 of FIGO variants of uterine fibroids. Additionally, the mass or so-called adenomyoma is poorly defined and blends. We need to understand that there is a surrounding myometrium which is forming pseudocapsule of compressed myometrium in case of a uterine fibroids. So, in case of uterine fibroids, you have a circumferential kind of a vascularity, number one. That is because of pseudocapsule created by compressed myometrial tissue. In case of adenomyoma, so adenomyoma should be differentiated from focal adenomyosis. So how do you do that? So focal form of adenomyosis, which is not in direct continuity of junctional zone. So if it is in continuity with junctional zone, it is focal form of adenomyosis. If it is distinctly away from the junctional zone of uterus, it needs to be termed as adenomyoma. Just to re-emphasize once again, a focal form of adenomyosis is not in direct continuity with junctional zone is called as a adenomyoma. When it is in continuity, it is called the focal adenomyosis. And to differentiate adenomyoma from the fibroid, we can take into consideration a pseudocapsule or a compressed myometrial tissue which shows a classical circumferential kind of a vascularity in cases of a fibroids. So it's as simple as that. Literature also mentioned about extrauterine adenomyoma, which could be distinctly away from the pelvic cavity into the abdominal cavity. Just to mention about ACM, these are juvenile cystic adenomyoma. It is due to presence of a endometriotic or adenomyotic deposit at the insertion of round ligament below the insertion of interstitial tube of fallopian tube, characterized by abnormal contour on 3D. On many instances can be taken as some or the other uterine malformation. This disease is accompanied with severe dysmenorrhea. All these three senior lobes depicts a classical adenomyoma, which is characterized by a hyperechoic heterogeneous area surrounded by a mantle of the myometrium, and this is in close proximity to the lateral ends or the cornular ends of the endometrial cavity. Now here also you can see that the uterine cavity is malformed in shape and there is a mantle of myometrium adjoining a classical feature of a focal ACM lesion. Let us take few cases and how one can report. Now, in this patient, you can see that it's a diffuse, severe variant of adenomyosis involving anterior and posterior wall of the uterus, and predominantly it is of a cystic, non-cystic variant. And it is involving all layer 1, 2, and 3 of the myometrium. So I have taken into consideration all the 7 features and I have reported it accordingly. Now here, can you see this hypoechoic infiltrates in subserosal surface, which is nothing but a more than 5 millimeter infiltrates below the serosal surface. So typical report description in this individual was diffuse non-cystic moderate adenomyosis involving all myometrial area. Here you can see here in the fundal and the anterior wall, all layers are involved and with negative sliding sign, and predominantly it's a non-cystic variation. Now, can you appreciate this? You can see, it's a retroverted uterus, classical features. Now, here you can see that there is a adenomyosis. I can see that there is a endometrioma on the left side. If I track it down well, it was sometimes confusing with the hematosalping on this side, but here I can appreciate that there is a hematosalping on the right side very well. So adenomyosis with ovarian endometrioma and hematosalping. Whenever we say it's a focal adenomyoma, typically what do we say? Whenever there is a translesional kind of a vascularity. Can you appreciate the translesional vascularity? And why I would say that it's a focal adenomyoma? Because it's a focal lesion, because it is distinctly away from the endomyometrial junction zone, which is thickened one. So I am dealing with a focal variant of adenomyosis, which is not in continuity with the endomyometric junction zone. Hence, I am going to call it the focal adenomyoma. Now, what about this now? Now here the endometrial cavity is irregular. I can see that the endomyometrial junctional zone is thickened in some part, interrupted and irregular in one part. I can appreciate some amount of focal lesion here, but this lesion is in continuity with endomyometrial junctional zone. So am I going to call it as a focal adenomyoma? No, I am going to call it as a focal adenomyosis. At the same time, on color Doppler, I need to look for a circumferential vascularity to distinguish it from fibroid or a non-fibroid entity. I also can see some of the islands distinctly separate from the endomyometric junction zone and spike. And this is a classical focal adenomyoma, distinctly away from the same, showing vascularity within the lesion. Again, a focal adenomyoma versus fibroid kind of a distinction. Whenever you are looking at adenomyosis, it is my duty to look for other features of endometriosis in the form of ovarian endometrioma or a saucer-shaped lesion involving the bowel to be stated as the deep infiltrating endometriosis involving the bowel, and that can be seen and demonstrated by retrocervical sign of fixity, by absent sliding sign, and also looking at torus and uterosacral ligament, which we'll see in the due course of time. So reporting template usually is consisting of uterus position detail analysis, ovaries position, presence or absence of endometrioma, fixity and tenderness, retrocervical deep infiltrating endometriosis in cases of IDEA protocol, looking for bowel nodules and multifocal endometriosis, and also looking at kidney, ureter, and bladder in patient with suspected deep infiltrating endometriosis. That's a reporting template. So this is the last line, which I personally believe is always across all profession. Consistency is the direct product of ethics. So if you follow protocol-based ultrasound in each and every patient, definitely you can reach to a higher level of success in your professional career. Thank you very much for your patient listening. Thank you.
Thank you so much, sir, for this excellent lecture, and the images were absolutely fantastic. Anyone is having any questions, so we can take some questions.
I think in terms of audience, suppose if anybody wants to ask any questions, you need to identify yourself, number one. And secondly, just ask a specific question rather than asking individualized query about a specific case which he or she has encountered in day-to-day practice. So in terms of conceptualization or images or scene loops, what you have seen, if you want to revisit any kind of a specific feature during the talk that you want to once again see, if it is if everything is okay, then there is no issue.
Yeah, we have one question, sir. From Pankaj Rote. Can adenomyosis exist in the normal sized uterus?
Yes, it can use. It can. See, basically, it can be present in case of a normal sized uterus as well. So in terms of characterization of direct and indirect signs by 2015 and 22, it's very, very important. It can be present in normal size. And we need to follow the specific signs as we have seen, starting from direct and indirect signs.
Yeah, so then Dr. Prafulla wants to know the difference between the adenomyoma and focal adenomyosis once again.
So in terms of focal adenomyosis, it is always and always in continuity with endomyometrial junction zone, which is abnormal in that case because we are dealing with adenomyosis. Now, if features of focal adenomyosis are present away from endomyometrial junction zone, which is abnormal. That means a zone of focal adenomyosis, which is not in continuity with endomyometrial junction zone, which is abnormal, is adenomyoma.
Thank you. Inbox is flooded with all the appreciation. Yeah, we have one more question, Dr. Ruchika. How to diagnose scar endometriosis?
We have a specific session on that. I mean, that's completely. But just to give you a feature in terms of a scar endometriosis, there are two kind of a variants. One is a scar endometriosis of previous single or multiple scars involving anterior lower segment, and there is a scar endometriosis where the laparoscopic port scars, the anterior abdominal various scars, also can have features of a scar endometriosis where typically a spiculated margin hypoechoic lesion is noted, which is remarkably tender, which is described in the literature as weeps during phases of menstruation, characterized by intralesional flow features, and it will have hyperechoic heterogeneous areas within this hypoechoic irregular mottled spiculated appearance of scar endometriosis.
Okay, then we have another doctor, Dr. Saurabh, saying how to differentiate fibroid and adenomyoma easily and how common is their coexistence?
See, they can coexist. So in terms of fibroid versus focal adenomyoma, I do agree on many instances it is pretty difficult. But again, focal adenomyoma is a form of focal adenomyosis away from endomyometrial junction zone, characterized by features of cystic or non-cystic variants of adenomyosis with intralesional vascularity, and there is no zone of compactum of pseudocapsule as characterized in cases of a fibroid. In case of a fibroids, typically there is a heterogeneous solid kind of a lesion, which is focal one, can occupy any of the wall, including continuation with endomyometrial junction zone, typically characterized with irregular contour when it is associated with serosal bumps. Also, feature of pericapsular or perilesional circumferential vascularity could differentiate between that. But again, in patients where it's a degenerating fibroid, long-lasting tender fibroid, fibroid with cystic degeneration or fibroid in cases of pregnancy, it is difficult to differentiate it from focal adenomyoma.
Okay, then we have Dr. Shrenik asking at what age group we should not report adenomyosis?
In terms of literature, I never found such kind of a thing, but practically I would say in case of younger age group, whenever focal adenomyosis is present, typically at the corneal end, we call it as ACM, juvenile cystic adenomyosis. But in cases of, so you can say that menstruating females and there is no tire phenomenon, that is the tissue injury and repair kind of a phenomenon or retrograde menstruation. Maybe in younger age group, maybe around onset of menarche to childbearing age. That could be the age in which probably ACM can be seen, but adenomyosis can be missing.
Okay, so then we have another question from Dr. Sapna. How to differentiate penetrating endogland at junctional zone from early endometrial malignancy?
See, the classical feature of endometrial malignancy in case of a postmenopausal female is indistinct thickened endometrium. And usually in those patients, we do not get a thickening of endomyometrial junctional zone. The classical description, so I have shown you one case of postmenopausal female with thickened endomyometrial junction zone and echogenic extractions. So in case of endomyometrial malignancy, there is a thickening of endometrial triple line configuration is lost. It is inhomogeneous. For that age group setup, it could be the practical cutoff level nowadays is as low as 5 millimeter in some of the Western worlds. But the endomyometric junction zone is never thickened in case of CA endometrium. When you put a color Doppler in case of a thickened endometrium with few of the asymmetrical cystic spaces, hyperplastic variant is difficult to distinguish from CA endometrium. In case of a CA endometrium, maybe some associated minimal amount of fluid may be seen in case of postmenopausal female. But I would say may not be a difficult. The difficult entity would be a known case of adenomyosis, diffuse variant involving one or the other wall, presenting as a bleeding PV in postmenopausal phase, where the high degree of suspicion in terms of CA endometrium is there. That is the difficult scenario.
Okay, then we have Dr. Versa. We can take a few more questions, right?
No issue at all.
Yeah, Dr. Versa is saying any necessity for follow-up scan in case of adenomyosis, both focal, diffuse, and for adenomyoma.
All the cases who have been put for medical treatment need sequential follow-up. There are two entities in terms of follow-up. Few people say that if persistent of symptoms of cyclical severe dysmenorrhea warrants for a follow-up, or patients where there are absolutely no symptoms, depending upon the medical treatment, in those patients, annual follow-up is mandatory.
Okay. Then we have some unknown person. Sometimes we find tiny cystic foci in the junction zones only. Myometrium is homogeneous. When can it be?
This is adenomyosis. Take it for granted. In any circumstances, beyond the endometrial cavity might have cystic space because we have a glandular endometrium. Beyond endometrium, within the endomyometrial junction zone, which is distinct, regular, irregular, interrupted, thickened, non-thickened, within that space or beyond that, any space of any size which is of cystic variant has to be adenomyosis.
Okay, then Dr. Saurabh is asking, can there be diffuse adenomyosis with normal junctional zone?
Unlikely.
Okay. How to differentiate cystic adenomyoma and acum?
Cystic adenomyoma and acum. See, as we have decided, adenomyoma are usually away from endomyometrial junction zone. Okay, that is number one. Secondly, if it is a cystic variant and if it is at the cornual end, closer to the interstitial portion of the tube, then it is difficult. But usually all the acums, they are always at the cornual end. That is the interstitial tube of the tubal zone because of juvenile adenomyosis.
Okay. Then age of appearance adenomyosis, can it occur in young patients?
Pardon, can you repeat, please?
Age of appearance adenomyosis. Full stop. Can it occur in the young patients?
Unlikely, really. I have not seen, neither I have read in literature.
Okay, any other talk? Should subendometrial cyst be reported as adenomyosis?
Yes.
Okay. That's it, sir. Otherwise, we have, I think, covered all the all the questions. Any further questions? Any session on DIE? Yes, we have it on the third session. So, okay, let me just tell you, we have the second session on this Guru Gyaan series on the 5th of September, and that will be on 3D fibroid mapping, taking care of clinical implications and reporting. So that we will be doing on 5th of September, same time, 8 p.m. We'll be sharing the link and the details very soon. to all the delegates who have joined today. So thank you so much everyone for joining. It was wonderful session from sir, and sir, absolutely fantastic session. Everyone is, our inbox is totally flooded with the all the appreciation. Thank you so much, sir.
Thank you. Have a nice time. And it's really in the world of people where they don't want to spend on the screen not more than 30 seconds and watch reels, followed by reels and Twitters and the world. They have been very kind enough to listen to me for a period of more than 45 minutes. So I am thankful to them as well.
Yes, we had around 160 plus delegates today, so it was a fantastic thing. Okay, thank you so much, sir.
Thank you.
Yeah.
Okay. Good night.
Yes, good night, everyone. Good night.